first panel, I will stay on stage to moderate, and I will call Cave, Sebastian, Paco, and Jordi to join me on stage. Please, you can applaud the speakers. Please. You can sit here, where you want, yeah, here. Perfect. Yeah, please. Thank you very much. So I was telling you we have a very exciting panel today on this topic with brilliant people. I had the chance and the opportunity to discuss with each of you and your teams, and we had I think a very complementary insights coming from all these speakers. So Cafe Savi is Senior Managing Director at the Global Health at Accenture. Francisco Lupianes is CEO and partner at Open Evidence Predict By. Sebastian Ziegler is Chair of Your Privacy, and I will present you, and you will start, so I will present you more in detail. And Jordi Barretina, he's CEO of German Trias y Pujol Research Institute, IGTP, an institute from Catalonia, very famous here and very powerful as well. Thank you very much to accept our invitation. So we will start with you, Sebastian, if you wish. You have a presentation, I think. Yes. So please go. I will let you that, but just to present you in a few words.
Sure.
Sebastian Ziegler is by training a lawyer, an economist, an innovator, I would say. Has been somebody who worked a lot in different environments. He worked a lot on the topic of Internet of Things in smart cities, in the question of data governance with your privacy, which you share the expert panel at the moment. Is a huge work for Europe around GDPR, the data protection, and the personal data privacy protection. And you're member of many projects in Europe, very famous in Europe on project of research and innovation, and working with the ECH Alliance actually in one of them, and you will talk about your experience, your views from your privacy on this important dilemma, so innovation versus privacy in Europe. Please,
Thank you very much. Yes. So good morning to all. Thank you for joining us for this session. Thank you again for ECH Alliance for organizing this session. I think it's a very timely period of time to address very important issues. As we all know, we are entering into a phase of digital transformation which is impacting all the sectors of the society, but in particular the health domain is massively impacted by this. In the positive sense, but also that requires to address a certain number of challenges. So I will try to share some perspective briefly based on one of the projects that we have the pleasure to work on together with ECH Alliance, which is Gatekeeper, which is a European research project, and more generally trying to bring some of the perspectives and challenges we will need to face in the years to come and in the months or weeks to come. Let me start by a few words about Gatekeeper. So Gatekeeper is one of the projects that was mentioned earlier, and one of the ambitions of Gatekeeper is to say, okay, we now have different stakeholders. As we all know, almost everybody is impacted. We can say that everybody is impacted by health, either individually or collectively or professionally. In this context, we have different stakeholders, complex ecosystems, and there is an opportunity to mutualize data, to share data, to create value, to support research by sharing data, to provide new services to elders, to aging people. And this requires to have new platforms. So what Gatekeeper tries to do is to support the development of new platforms for data sharing, for service sharing. So finding different ways to bring together the different stakeholders and enable to mutualize, to share, to collaborate. As such, that requires to address quite a number of challenges. In particular in Europe, as you all know, we have the European General Data Protection Regulation, which has set a certain number of fundamental principles, stating that personal data is not something as anything else. It's a fundamental right. Anyone, anybody should have a control on his data. So it's not only about privacy. That's a mistake. People think often that GDPR is about privacy. Privacy is only part of it. It's about data ownership, data control. As a data subject, as a patient, I have rights on my data, even if they're public. So even if I make them publicly available, they're still protected by the GDPR, which means that the GDPR is really here to empower data subjects, patients, on controlling their data. And in the GDPR, you have quite a number of requirements, obligations. So any health data is considered not only as a personal data, but as a special category of special data with a higher level of protection. In this context, if you do research, if you want to support innovation, you have to play by the rule and to respect this regulation, which means in Europe that you need to address quite a number of issues. For instance, you need to assess the impact on data subject. You need to assess what will this new technology or these new platforms have in terms of impact and risks on the freedoms and fundamental rights of the data subject. So that's really something which is new, because before we used to say, okay, let's develop a technology, and once it's developed, we will see and we will adapt it to the market. That's not possible anymore. You need to start by assessing the risk for the person, for the patients, for the different data subjects. You need also to do something very new, which is required by Article 25 of the GDPR, is to ensure that when you develop new technologies, new data processing, you must work on data protection by design and by default, which means that for a research perspective, from researchers, industry, it requires to internalize the GDPR and personal data protection from the very start of the research. And that's quite new, because again, usually we started by developing a new technology, putting it on the market and trying to adapt it to the regulation. Now you cannot do it anymore. You need to already internalize the regulation in the research process, which means that you need to change the way you do research. You need to have a more multidisciplinary approach. You need to engage with experts in regulations, with experts in end-user engagements. It's also very much aligned with the notion of open science, engaging with the different stakeholders. So it's really a paradigm shift for the research. And that's something which is here to stay. A few other elements, data minimization. And that's very interesting, because on one hand, we are requested to try to minimize the data we collect, but at the same time, if you have not enough data, we are minimizing or impacting the potential of developing new solutions. So we are facing quite a number of very interesting dilemmas. They're not simple to address, but very interesting, very rich. Data breach notification, for instance, cross-border data transfer. As soon as you have research projects with different countries, you need to find ways to share data with your peers, with your colleagues. And if they are all in the EU, that's already quite okay, it's not too complicated. But let's imagine that you have partners in the research projects in, let's say, Israel or US or other regions. Then you need to see how you handle the sharing of data with your colleagues. And we're all working on the same objectives to enhance health, to support new technologies, new solutions, but we need to handle these practical regulatory obligations. So how did we do it? How did we address it in the context of Gatekeeper? So again, addressing the different layers. So trying to ensure, again, data protection by design, trying to work on the risk assessment, trying to find ways also to integrate the different partners to work on the same principle. And that's very important, because in our research projects where you have different partners, each partner which is collecting data is a data controller. It is responsible for the processing of this data. It is responsible not only for the way the partner is processing data, but also for the way the processors and sub-processors of these partners are processing data. So it makes a very complex web of responsibilities, of liabilities to address. And that requires to bring the different stakeholders, partners, to work together, to learn from each other, to collaborate, to align on a certain number of procedures and principles. And then you have all the issues related to risk mitigations, to pilots, implementations, monitoring, and so on. Since time is passing. So one of the approach we try to develop in the context of Gatekeeper is to say, okay, that's a highly complex set of requirements. We have different stakeholders which are not necessarily lawyers, so we need to find a way to bring everybody at a certain level. But so what is very important is to be able then to communicate to third parties that we are doing things right. We are really following the rules. We are really implementing and walking the talk. And in this sense, one very interesting mechanism is certification. That's why in the context of Gatekeeper, we're working on specific extensions of certification. And to do that, we leverage, as it was mentioned earlier, on certification scheme which has been developed in the context of Horizon 2020, context of the European Research Programme, and which has been designed to assess the compliance of any data processing with the GDPR. And this certification scheme is named Euro-Privacy. It's handled by an international board of experts who are serving from different universities, different experts in data protection, and which aims fundamentally to address how we can ensure that any data processing is complying with the GDPR. And the interest of this approach is it's not only to provide a kind of general seal, but really addressing emerging technologies, addressing data processing using artificial intelligence, distributed ledger technologies such as blockchain, Internet of Things, and so on. So we're trying to embrace the compliance at a very deep and technological, compliant and aware approach. And then what we are doing in Gatekeeper is to leverage on this scheme and trying to see if there are needs to extend it in a certain number of directions. If we need to address and to include new criteria. And to address in particular one very important element is the emergence and the arrival of the Artificial Intelligence Act in Europe. As you know, there are new regulations which are coming. So to regulate the way artificial intelligence is used in Europe, we have the Data Governance Act already, which has been adopted, which defines the way data should be made available and shared. That's very interesting, because on one hand, we have regulations which try to minimize the data processing and data sharing. At the same time, we have regulations which require that we should make a certain number of data available to third parties. And then there is a new regulation coming, which is under discussion, which is the Data Act. And the Data Act will also impact the way data, in particular from IoT, should be made available to the patients, to the different stakeholders for reusability. So in this context, there is a need to redefine and to develop new solutions, new approaches. And that's where collaborative projects such as Gatekeeper are very important, because they bring the different stakeholders together to work together, to find solutions together with real cases, with real pilots, with a reality, really rooted in the reality. I will skip very briefly. I will not dive into the details of Euro-Privacy, but you can find more information on europrivacy.org about the scheme if you're interested. And then what we try to do is really to adapt it to the specific needs of Gatekeeper, to address what should be assessed in the context of a new platform for data sharing. So typically AI algorithms that will be used for processing data. Why? Trying to understand what is the value proposition of certification in such a context for the different stakeholders, for the hospitals, for instance, to reduce their liability or risk or reputational risk, for the industry, for the physicians. How does it fit with the different stakeholders, and how can we co-create a model that is aligned and adequate with the needs of the practitioners? Now, maybe just information in case you would be interested. There will be a meeting that we organize in April with Gatekeeper, with different projects, to specifically address this question of how to ensure health data protection and compliance in a more and more complex environment. And if you go to privacysymposium.org, you will see quite a number of information. There will be a whole set of sessions. But in particular, there will be a dedicated workshop to discuss this notion of health data compliance and protection. So you're very welcome to join. And I think I've just on time, so thank you very much. You will find some pointers to continue, and it will be a great pleasure to discuss with you at the break and to continue and to follow up on this question. Thank you very much for the invitation.
Thank you very much. You can push it to Kaveh.
Yeah.
It's for you. Thank you very much, Sebastian. We will thank you for the very interesting presentation. We will have the opportunity to ask questions and to have a debate after the 4 presentation. I will ask to you, Kaveh, now to present. I will introduce you. Dr. Kaveh Savavi is a very well-known expert in digital health since many years. Senior Managing Director of Global Health at Accenture, but you are at the beginning a medical doctor in internal medicine and pediatrics, if I'm correct. Yeah. But you have as well graduated from the DePaul University College of Law, so you are as well a lawyer or a Juris Doctor. So you have the 2 hats, perhaps, and your point of view on AI and the development, the state of play and the development in the next year, very interesting for us. Thank you very much, Kaveh.
Thank you. Julian, it's great to be here in Barcelona. Thank you. I want us to zoom up a little bit, because we're going to talk a lot about artificial intelligence and the how, and I want to talk about the why. the World Health Organization, before the pandemic, estimated we would have a 15 million person shortage of healthcare workers by 2030. And the pandemic has accelerated that significantly because it's caused people to leave the workforce. In the United States, where I'm from, it's estimated that over 600,000 nurses will retire by 2030. There is nobody coming behind that group. The staff are becoming patients. And when we talk about artificial intelligence for the past decade, and we talk about the doctor as the doctor AI and the interaction of a human with a machine for a diagnosis, it's fantastic to think about how healthcare can be better because of AI. But what I want to talk to you about is what I think will be the far more transformative effect of AI, which is it's going to have to be the solution to solving what is essentially a critical problem, which is a system that is dependent on human beings to do the work, where there simply aren't enough people to do the work relative to the demand. So if you actually look at how healthcare has been performed since its inception, it's largely about an interaction between people. And in fact, as we have expanded the healthcare systems globally, we've expanded the number of people that we need to do the work. An economist named William Baumol described this problem as the cost disease in the 1970s, and he said basically healthcare, like education, keeps getting more expensive because we keep adding people, and the wages of the people will grow at the rate of the economy, and then science and an aging population means that in every rich country in the world, costs grow faster than the country's capacity to pay for it. We have an affordability problem, and now we have a different problem, which is we have a crisis of our ability to do the work. Healthcare has actually been losing productivity really basically since we've been measuring it. And in fact, to make this point, 2 years ago, McKinsey did a fascinating study where they looked at healthcare in the United States and they asked the question, compared to the rest of the economy, how does labor, capital, and technology relate to economic expansion? And basically what they discovered is if you looked at the US, our economic expansion, about a quarter of it comes from labor and the rest comes from capital and technology. But at the top, you'll see 99% of the growth in healthcare has come from labor, compared to only 25% for the rest of the economy. And technology has been a net drag on productivity in the United States, 13% loss of productivity. That's primarily because doctors have to type. And the reason doctors type is it's the only way for them to get structured information into a medical record, and they've lost 10% of their time because of it. That is an unsustainable problem when we have a labor force that is aging out and the bedside demand is growing more quickly. Now, why isn't it that we haven't been able to benefit the way the rest of society has been able to benefit? Largely because technology has primarily been available only to do routine tasks. This chart from The Economist shows job creations over the last 20 years. The two lines that go up represent non-routine tasks, both physical and cognitive, and the lines that are flat represent routine tasks. Technology replaces routine tasks. The problem in healthcare is most of what we do is not routine, whether it's physical or cognitive. And only until artificial intelligence became available do we have a tool to begin to take over some of the non-routine tasks. So the real promise of artificial intelligence is the first time that technology is now available to start doing the jobs that can and need to be done by human beings. But we're not talking about technology substituting for human beings. The biggest misconception people have is that technology will replace humans. What we're actually going to find is a model where technology and humans work side by side, and that has significant implications. In fact, we surveyed a number of healthcare leaders globally, and we asked them, where do you think artificial intelligence will have the biggest effect on healthcare? And the way to read this chart is the dark blue lines represent the answer, which says it'll have a substantial impact, and the purple represents the answer, it will have a transformative impact. And what's interesting about it is everybody answers substantial to all kinds of categories, clinical care and operational care, but the purple, which is transformative, is primarily relegated to non-clinical areas of care. So what they're saying is, sure, artificial intelligence will matter in healthcare, but it's not going to be because it's going to substitute for clinical judgment. It's because it's going to take over other jobs that people do. Not the hard jobs, the jobs that only humans can do, the jobs that require judgment and empathy, but really the jobs that are best suited for technology that can do routine and slightly non-routine tasks. In fact, a number of estimates have been done, and it turns out that somewhere between 30 and 40% of the tasks that are done by people in healthcare, whether they're non-clinical or clinical, can be done by a machine, either a physical machine or a cognitive machine. And the rest have to be done by human beings. There is no possibility of replacing a doctor or a nurse with a piece of technology. There's a doctor in the United States who, a physician leader who has famously said any doctor who can be replaced by AI should be replaced by AI. Because in fact, what we do cannot be done by the machines. However, that means that we're not going to actually replace jobs, we're going to change jobs. And this becomes a very significant challenge for our healthcare system and our operators. Because when I take 30% of someone's work away, and I leave them with 70%, their job isn't the same job it used to be. And now I have to reorganize everybody's work to work alongside the machine. This is a very different model than traditional simple automation where you take someone out and you put a machine in and the other people keep doing what they've always trained to do. We're changing everybody's jobs at the same time. Our estimates are that for physicians, somewhere around 25 to 30% of the work that they do today, this is primary care, can be replaced by either the patient or a technology or the patient using a technology. So instead of having a shortage of labor, we have the ability to scale our professional staff and cover more people. That way we have at least some hope of closing this access gap. We're starting to see some really interesting thinking going on in the developing markets. What they're discovering is there are simply not enough healthcare workers. We've known that for a long time. The problem just gets worse. And we really can't, we don't have digital connectivity for all of these people, and in some cases we'll never have digital connectivity. So the idea that they're going to be able to be connected in some fashion is also not realistic. However, with the rise of things like edge computing and 5G, we're now beginning to work on models where we can take a person who lost their job because of complete automation, and without making them a full-scale healthcare worker, and just giving them a little bit of training, and giving them a smart device, we can actually allow them to walk into their communities, and by use of the device, become a functional healthcare worker. That model had never existed before, and it eliminates the need for continuous connectivity. So we're really at an interesting cusp, with all of the convergence of these technologies beginning to allow us to solve a problem that we really didn't have an answer to until recently. The workforce of the future looks very different than the workforce of today. And this is an idealized version. This is actually a non-clinical workforce in healthcare. This is a financial one. So take this as a model, but don't take the numbers specifically. But what you're really doing is you're going from a workforce of humans that work for you to a workforce that is comprised of bots, of some gig workers who have highly specialized skills, and some permanent employees. That's a very different experience. It causes a few things to happen. The first thing is that humans and machines have to work together. In manufacturing, we've already done this. It's called a cobot, a human and a computer, or a human and a robot co-working team. That requires a whole set of skills for humans that we don't have today, that we're going to have to develop. That also means that we don't know what work is going to be like, because when you take the easy jobs away from people, and this has already been modeled with physicians, they'll complain about doing tasks that are not high judgment tasks, but as soon as you take it away, they'll complain even more because they need the downtime. It turns out that the brain needs rest. We don't know what to do when we take all the easy jobs and we give it to machines and we ask people to do only the things they can do continuously. We are embarking on an era where we're going to bring a solution that we know can scale human labor, but we have no idea how it actually works. And this is a journey we're going to have to test and learn our way through in order to be able to evolve. And really right now we're at a place where we need the leaders to go first and show us what's possible. And then the rest of our organizations, rather than waiting, are all going to have to learn how to experiment on this journey. And while all this is going on, we're going to have to deal with the reality that artificial intelligence has a number of limitations, including practical limitations that others on this panel are going to talk about, that are going to make the evolution of this technology move a little more slowly than we would hope it to be. So on the one hand, I see this tremendous opportunity. In fact, I see this critical necessity. On the other hand, I recognize that there's a lot of pragmatic realities between where we're at today and where we need to go. And what this really provides for us as leaders, whether we're entrepreneurs or whether we're leaders in healthcare delivery system, whether we're in technology, or whether we're in any part of the ecosystem, is the recognition that the world looks different and we have to start working toward that world. And it looks nothing like the kind of environment that we've been working today. I'm going to end with this statement from Joseph Campbell. He's an author, but I think it's very apropos. If you want to change the world, you have to change the metaphor. And what I'm saying is that essentially we're at this point now in healthcare where for the first time in at least 100 years, we're about to change the metaphor. Thank you, Julie.
Thank you very much, Kaveh. Thank you. Very, very important topic around the workforce, and you were talking about the jobs changing in the future, and it's a very important topic. We can come back to that during the question. I will give the clicker to Francisco. Francisco Lupianes is partner at Open Evidence. He's as well professor at the Open University of Barcelona. He's an entrepreneur, having more than 15 years of experience in the digital health sector, but as well beyond this sector in other aspects or other domains. You've worked on data analytics, data science, on regulation, but as well on policy making. You are working for private and public organizations. You are an expert for the European Commission, the European Parliament. So please share us what will happen in Europe around this topic of data governance and AI. Paco.
Thanks a lot. Thanks a lot for the invitation. It's a pleasure to be here. Before we were talking about the what somehow. Now we are going to talk about the how somewhat, and I want to focus on the how through regulation. Sometimes we see in the regulation as a barrier, and here in Europe we are currently facing so many challenges, and one is the data strategy, and the European Commission has put out several initiatives on data and on artificial intelligence to make Europe also the center of the data regulatory aspect. That's why I think we are in front of an opportunity to understand regulation not as a barrier, but as an enabler, okay? In Europe, we have a different way of doing things. We are global, obviously, but at the same time, we have our values and our fundamental rights, and we have some aspects that differentiate us from other parts of the world. And we can take this, the regulation, as an advantage and not as a barrier or as a stopper. GDPR is a great example of this, okay? The current landscape on artificial intelligence and healthcare is huge. There are all areas, as it was, all areas of healthcare could be, let's say, related to AI in the short term, in the medium term, and for sure in the future. From public health to care services to health system to self-care. So all the areas of healthcare can be, let's say, linked or close to artificial intelligence, okay? And here we go. We talk about trust. We talk about transparency. And there are currently in place several legislations that apply to these areas, okay? So sometimes when you listen to our startups, SMEs, or even governments talking about, look, AI is going to destroy whatever, please take a look at the legislation, because the legislation is there to guide us in this innovation process. So when we talk about safety, technical robustness, or accountability, we have the GDPR, but we have also the medical device regulation there that we can use, that we can learn, that it can guide us, so to speak. We talk about privacy, security, and data governance. Again, GDPR is there to help, and we need to interpret it correctly, and it's there to guide us. But it's also the European Convention of Human Rights or the Cybersecurity Directive. We can read, learn from there, and see how we can guide our artificial intelligence initiative, so to speak. Transparency, again, GDPR as an enabler, not as a stopper, because it can be interpreted and it can be adapted to the reality. Diversity, non-discrimination, and fairness. Europe has a lot of laws in place that can help us to disentangle what do we mean by trustworthy AI. Okay? I trust my neighbor. I don't know if I trust the algorithm. Okay, there are laws in place that can help us to build this trust and how we interpret trustworthy AI, okay? From Goods and Service Directive, Gender Equality Directive, Race Equality Directive. So what we mean by trust, we can get inspirations from there. Other issues, robotic, cross-border care, it was already, loss and harm, liability. Medical device regulation covers some parts of the liability. I'm not sure if it covers others, especially when we are talking about consumer law, okay? Again, there are laws there that can inspire us when we develop our AI initiatives or when we put in place our AI initiatives. But the problem is, or the solution is that more are coming. The European Commission is currently proposed the Digital Service Act and the Digital Markets Act. Both acts are going to regulate, or will try to regulate, the data ecosystem at both the SMEs startups, the first one, and a large online platform, the second one. So we don't need to see those laws as antitrust or monopoly against whoever big player, but also as a facilitators for SMEs and startups. And the last one, the Artificial Intelligence Act. I think it's a must. I mean, we need to read this law. We need to read this proposal to understand what is coming. And the funny thing is that it could help us, because by reading some of the articles, by reading some of the recitals, it could help us to frame our algorithms, our solutions, okay? The European health data spaces. Again, there is the GDPR, but there is a wall outside the GDPR that needs to be, let's say, addressed, okay? There are already discussions on the how. Launching concepts like sandboxing, launching concepts like accreditation process. This concept could help us, could help hospitals to set up their data labs, could help entrepreneurs and startups to set up the test bed to test their products. And we can get inspirations from these laws. How we embed these laws or acts in the pipeline of creating the AI. I mean, these are 5 steps, are very, common. Define the objectives and the purpose and the requirement solicitation of the AI. What is the purpose? And in the medical device regulation, but also in the artificial intelligence regulation, intended purpose plays a key role. What is it doing? It's helping a doctor to take a decision. It's helping a patient to take a decision. It's taking the decision for me. This is very important because it will funnel all the regulatory aspects that come beyond. Data gathering and processing. Again, GDPR, European health data spaces, how we can access and analyze and assess data, how we can collect and process the data, how we can prepare the data, and how we can transform the data. Accountability is here to stay. So if I did the algorithm in a way, maybe when I go to put it in the market, they may ask me, look, what data you use? Is data from US? Is the population in Europe the same? The subjects you are, okay? So all these aspects, they have a link with the regulation, okay? Data modeling, evaluation, okay? At the end of the day, we need to evaluate the impact of our algorithms. And it's not just going up to the moon or to Mars or all these big words. No, it's treating a patient better. What does it mean? What is the health outcome? And what are the savings or what are the costs? Are we willing to pay for this, yes or no? This is going to be needed in both, in the evaluation, in the lab settings, but also when we want to deploy, monitor, or do the surveillance of our AI systems. It's not like we are giving, here we go, here is your AI system, bye-bye. No, it's kind of a service. It's not a product. So a monitoring and surveillance system needs to be in place, okay? This is how it looks like, the full process with the full laws. Okay, I'm not going to go across all the graphs. I talked with Julian. We will use it in the debate during the discussions we will have. This is just to show that in every purpose, in every step, we have to address some areas. We as an SME, an innovative SME, we are able to produce algorithms, follow these rules, and we are able to also give advice to public institutions on how we address each of them. As I was saying before, the purpose, the outcome, what is the result? The result is a number for a doctor to take a decision. The result is an alarm system to do something. This result matters a lot when it comes to the regulation. The level of control of the users and the end user's qualification. I'm going to skip that. Well, let's stop. I'm checking the time. Sorry about that. This is how we can do a taxonomy. If you're familiar with the medical device regulation, it has class A, class B, class C. To some extent, artificial intelligence can go there in many cases. In others, maybe cannot. So what we decided is to establish like a matrix based on the level of expertise and the outcome to see what type of artificial intelligence we are building and to what extent which laws should be applied or how we should interpret the laws, okay? The raw data, the data processing, it's a key aspect. GDPR plays a key role, but the protection, security, and quality are linked to the transparency and the traceability. We will need to be accountable on how we did that and why we did that. The data modeling part, where the data science play, again, the validation is going to play a key role, and it's important to take this into account. And finally, the outcomes. Okay, how we are going to measure the outcomes. How we are going to measure the outcomes and how we are going to monitor these outcomes. Because again, we are close to a service than to a product, most likely, and this we will remain accountable. So it's important to understand in the deployment settings, in the deployment settings, what type of approval our AI system will need. Is it liable? Is the doctor liable? Is the patient liable? Is the device liable? We need to interpret this. Safety level, security, warnings. Now we have the leaflets for medicines. AI algorithms may come with a leaflet. Doctor, please, before taking a decision, you should know that. Or patient or citizen, please, before taking the advice, you should be aware about A, B, and C. This is coming. This is coming, and we will all have to face this. Levels of evaluation is about technical efficiency, potential clinical efficacy, diagnostic accuracy, diagnostic thinking efficacy. All these aspects, we are not building things in an isolated manner, okay? And the regulation at some point will ask you for these aspects in the evaluation. Lastly, again, maybe we need to start considering regulation as an enabler. If we are not going into the Wild West, thanks to the EU values, so to speak, we may find in the current or in the proposed regulations inspiration to funnel all the creativity, all the innovation, and then go faster to the market. You need to realize about this aspect the sooner the better, let's put it that way. Otherwise, you may get to the market and say, look, it's not working. It does not have A, B, and C, okay? Thanks a lot.
Paco, thank you. Thank you very much. So we will have a lot to say about this AI regulation upcoming in Europe, certainly in the debate, and to compare and contrast as well with US and with Asia as well, with Kaveh being with us today, perhaps to compare this regulative approach. I'm very pleased to now introduce Jordi Barretina. Jordi is CEO of German Trias Epijol Research Institute here in Catalonia. Jordi is a Catalan, studied here, obtained his PhD in biochemistry and molecular biology here in Catalonia, but your research on cancer brought you to Boston during many years. working first at an institute of the Harvard Medical School, where you develop especially the sarcoma genome project, which has been a huge step forward in this research of rare cancers. And then you join as well other institutes in Harvard and MIT in Cambridge. You've been as well the head of translational research at Novartis, so you have an industry profile as well, additionally to your research profile. In 2011, I think you joined Novartis, and 4 or 5 years ago, you came back home to Catalonia to lead this important institute. I was saying that in introduction. This institute is in Catalonia, and in Spain, a very important institute of research. And Jordi will tell us a few words about his view on AI and its development in the future. Jordi, the floor is yours.
Thanks, Julian. And I just want to say that, thanks for the invitation to be part of this panel. I guess I'm here representing, in a way, the research institutes that lie at the interface between the people who are trying to develop solutions based on research, grounded on research, using the data that is mostly in electronic medical records in hospitals and the whole health system here in Spain. So for those not familiar with IGTP, it's actually a research institute that is tied to one of the major teaching hospitals here in the Barcelona area, but there are a number of them that are trying to also contribute to this development in digital health. So being the last one in the panel, and for the sake of time, I'll go slideless. I'm just going to bring up a few points that hopefully my colleagues didn't bring up so far, at the risk of being a bit redundant, as we all describe the opportunities and the challenges. So I'm just going to talk a little bit about the opportunity that we have right now and the paradigm shift that some of them alluded to, and also bring up some of the challenges, because I really feel that we need to have the hard conversations now. Many of these hard conversations have been brought up during the pandemic on how to use the data, how to make the most of the data that is available. And if we really want health data to transform the world in the way that other types of data have transformed our lives, and you can think about a lot of fields where data is important in predicting lots of things, advertising and others. So we really need to think about how to break some barriers that currently exist. So first, I just want to, I'm sure that you will all agree with me that there's, at this time and age, with all the hype, all the technology that is being developed, all the people that are working on developing potential solutions to improve people's health, and many of them are you here in the audience. So it's really hard to predict the risk of a patient of contracting a particular disease. And it's actually not that easy, and I can tell you from my own experience, to predict which treatments will work in certain circumstances, in certain diseases, and in particular in cancer, as I'm going to mention later. So that's where a lot of progress has been made in the last few years. So we're all excited about the technology that we have. We'll all agree that it's not a technology problem in many cases. The solutions are there, either from the public health systems, commercial solutions, etc. But it's really hard sometimes to predict, as I said, which patients will contract the disease. And I can tell you that a lot of risks for cancer are known, but there are many cancers that, as you know, are not easy to predict. And we're doing a lot of work based on data to get to those things, but it's not easy. And also in terms of predicting drug response, when you actually choose, or even choosing which treatments might have the highest likelihood of being successful in certain treatments for certain cancers, it's really, really hard. So, I mean, you might remember, for instance, the Watson case, where IBM tried to actually build a big infrastructure or use a lot of data to basically predict cancer treatments, and that was actually not such a successful endeavor. So the second idea is about these challenges and why it's taking so long. All this technology has been there, all the data has been being amassed over the last few years, in particular for cancer genomics, pretty much since the human genome sequence was sequenced at the beginning of this century. So there's been a lot of data that has been amassed, but it's still really hard, and there are a lot of barriers for implementation. One of the main barriers, and I think several people here already brought it up, are access to data, how to properly access to data. I really like Sebastian mentioning that the privacy concerns, which should be something we should be worried about, are not only about privacy, but also about the patients or the individuals having control of their own data. And that's something that I think we need to evolve in a way that, for instance, if we trust the banking system to do online banking, at some point there has to be some sort of system where patient data can be accessed and controlled, and consent can actually be managed by their own patients and individuals. And that's something that will probably help a lot with data aggregation, which is another particular challenge that we have right now when we try to do research projects. Sometimes it's easier in research, but when you actually try to implement those things in real life medical practice, that's actually really, really hard, because as you can imagine, in research, you can tolerate a certain margin of error, but when you go to treat patients, I mean, you really have to minimize that risk at the maximum level. So data being siloed in many different places. Sometimes it's hard to basically match identities because every system has actually different identity identifiers, and it's hard to cross-check and to link all those things. Consent, sometimes not all the data sets are consented the same way, and all these things will need to be worked out if we really want to make the most of the data health. So another, and of course interoperability, which I'm sure that will be a theme during the rest of the day in several of the panels. So another thing that has not been brought up so far is the challenge of the workforce. I mean, we're talking about the medical workforce, the caregivers, but in digital health and AI, etc., there are a lot of technology companies that are actually attracting a lot of talent, and sometimes it's really hard to basically attract talent to our operations in which we try to build health solutions based on data. So that's something that we're facing, for instance, here in Barcelona or in our research ecosystem, despite the fact that digital health is booming. And there are lots of startup companies that are being formed. Some of them are spin-offs of our institutes. But when it comes to actually even doing research and having people specialize in data science, so that's actually one of the things that we do face often. Then another topic that I want you to think about, and I think somebody mentioned the health inequities. So it's the fact that sometimes we don't have the data that we need to make the right predictions for all type of individuals. So for instance, we've been talking about the difference in regulation between the US and Europe, but also when it comes to population structures and ethnicity data, and for instance, in particular in genomic data, I don't know if you know that less than 5% of the genomic material in which research is based in the pharmaceutical companies is not from African descent. And for countries in Europe and others in other places that have received a lot of immigration, if their health systems in the future want to take care of all patients, and this whole evolution of our healthcare is not going to leave behind certain underserved populations, we really need to take into account that we need to gather this kind of data. And there are even now startup companies that are trying to gather, for instance, genomic data of African descent. And I could go on and on and on with challenges. I just want to also leave you with one thing that I think was brought up before, which is that technology is key, but the human factor also matters, and matters a lot. And now it's not about the workforce, what I want to say, but also more about the actual training and empowerment of patients and education on all these things that are about to come, and that we really need the patients to feel if they want to trust the system. I mean, we'll have to do our best job to educate the patient population to make the most of their data to be used for the health of the whole population. So with that, I mean, I know I've talked about a few challenges. Some of them have been brought up before, but I want to leave you with a positive note, and I want to go back to the cancer example. So in the last 15, 20 years, since late last century, I can tell you that we've seen a major progress in terms of cancer mortality, and also I've seen firsthand, and I've participated in generating some knowledge that has advanced the precision medicine in cancer care. But so I'm optimistic about the future. I don't know if it's going to be 4 years from now, 5 or 10, but we really have to start thinking about all these things and how to solve these issues if we really want to fulfill the promise of digital health and precision medicine-based healthcare. So thank you.
Thank you very much, Jordi. And about precision medicine and cancer, we will have a good speech as well this afternoon by Professor Valencia from here, from Barcelona, from the supercomputer. So we will come back to this topic. So thank you very much for all the 4 speakers. I think we had very different insights and perhaps topics for a debate between you now. We will take some questions from you in the audience, so please raise your hand if you have a question and somebody will bring you a mic in order to ask your question. I will ask you to present yourself when you ask a question, just to understand from where you're speaking, and feel free to address your question to the panelists. Do we have questions already? I will launch a first one. Maybe you're shy in this morning. A first one perhaps to take on one of the last points you mentioned, Jordi, and that you mentioned, Kaveh, as well, about the training, new jobs in the future, new way to practice medicine, but as well education for the population. You were talking about patients, education about the management of data. Do you have in mind some strategies, some tactics, or some examples you've seen either in Faculty of Medicine or in nurse school or for the population that you can share with us? Jordi?
Kaveh, you can.
Sure. Well, there's actually an emerging body of research, and the human machine researchers talk about this thing called the middle skill, which is how does a human that has to interact with a piece of technology to do part of their job work. And so, for example, there's this concept called intelligent interrogation, which basically, because the technology is answering questions, and because it keeps getting smarter based on answering questions, the way the human actually interacts with its coworker, who's a repository of knowledge, keeps evolving. And so you have to learn how to ask the question, and you have to learn how to get the right answer out of the technology. So you actually have to build a specific kind of competency in your human labor force in order to be able to take full advantage. Another competency is, what do you do with all the time that you get back? If you give someone time back, you can't just not do, it has to be released in some fashion. And people are talking about how do you rehumanize the time that's liberated and what other tasks, what other uses are there. So there's lots of interesting dimensions to this they're all fairly new.
Jordi?
Yeah, just to add to that sometimes for certain medical practitioners or for doctors and nurses, sometimes it can feel daunting to actually get into this, but they do not have to know the insides of the algorithms the same way they don't have to know the insides of the MRI machines or all other medical devices. They basically need to get the basics. I mean, the more they know about the basics and how it works and which outputs and which possibilities that gives them for better treating their patients, the better. But I mean, they definitely don't have to become biomedical engineers or computational biologists or so.
Yeah, a colleague of us in our board and one of the ambassadors of ECH Alliance, Rachel Dunscombe, who is in the AI Council in UK, is often talking about integrating AI in the healthcare settings, a bit like we are integrating a new co-worker, so a new junior resident, for instance, in the organization, in the hospital, and to have the same work of adaptation, integration within a setting. So it joins a bit this idea. Do we have a question in the room? Yeah? Gentleman there. Please mention your name, your organization, and your question, please.
I have to hold the microphone because...
Good morning. Thank you very much for the presentation. My name is Paul Furvoy. I represent the Costa Rican National IT Association. We're currently having conversations around digital health initiatives, but we seem to be trapped between the privacy regulation side and the data standards. We're trying to understand sort of how to navigate the route between privacy and data standards, where to begin. And I think we have a little bit of paralysis based on our analysis. So what recommendations would you give? This is a developing region, Central American country. We're looking at how to plan a route in this area. What recommendations would you give us?
Sebastian?
Yeah. So I would say, first of all, one very relevant approach is to start dialoguing, having contacts with other research groups and other constituencies. And in particular, if you want, so Latin America has its own regulation for data protection. It's evolving. There are more and more coordination at the Latin American continent regions. All the data protection authorities in Latin America are working together. There is a kind of common standard which is emerging in Latin America, which is distinct from the European ones, but which are both moving in the same directions. And that's, for example, what we have noticed while working in the Privacy Symposium next month in Venice, that data protection authorities from the US, from Mexico, from Brazil, from Europe, from Japan, are starting from different cultural environments, but with the same concerns. How to address in an efficient manner, how to find the right balance to respect the data subject rights while enabling data sharing and digital transformation. In this context, interacting with other regions, other researchers will be probably the first advice I would give. Then there is a lot of room to develop new standards, new data models, new standardized processes, new reference models to ensure that we can ease the data sharing while preserving and protecting the fundamental rights. So that's something which is not a dead end. As it was mentioned by my colleague, there is a huge potential for innovations. Again, the new regulations are not there just because someone would like to restrict our freedom. It's the results of a social concern. And if you reflect about it, it's the best way to address the market. Because if you develop a technology unilaterally without taking into account the concerns of the stakeholders, which are finally your end users, whether in terms of patients for hospitals, in terms of clients for a pharmaceutical company, if you don't address these concerns from the very beginning, you may miss the market. So it's something interesting to address and to be proactive. In this context, again, having international collaboration, exploring, bringing your ideas. Again, Latin America, Japan, many countries are developing innovative approach towards data protections, and we can learn from you. So it's not one-sided. It's not that Europe should teach to others how to do it. We have to learn from you. It's a challenge we all face, and let's try to find a way to work together to address this and to support each other.
Thank you. I take Paco and then Jordi.
Yeah, I would say that you raise a very important point, dialogue. The standards at the end are a kind of a tool that facilitate the dialogue between several actors. I think it's also important we are talking about trust, to generate ecosystems of trust within the boundaries of the regulation or within the boundaries of the standard, bring together all the stakeholders in this dialogue, put in the boundaries of the regulatory approach, and then work together. I mean, I like to put the example of randomized control trials. I don't know if there is a book about the history of the industry of randomized control trials, okay? But the way they set up the whole ecosystem to make things happen, we may learn from there to do artificial intelligence. Meaning that it's a public-private ecosystem, okay, funding, so to speak. Each individual brings something, adds something to the value chain, and each stakeholder takes something from the value chain. So regulation, put the boundaries, the dialogue through the standards, and then see how other things have been done. And I put the example of randomized control trials. Nobody will question the result, well, nobody, quotes unquote, because it could be improved, but nobody will question like how the process went, okay? So why don't we learn from there and we set up the same for developing an AI system with the current regulation and with the specific international standards. And these will be easily scale up because we have a common way of doing things where we trust each other because we follow certain rules.
Just briefly, a practical advice, which is I'm a real fan of pilot projects. So I mean, I know this might be like a big project. It might feel like that, but maybe you want to focus on a particular thing that you want to scale up later on, and of course assemble a multidisciplinary team in the line of what they were saying. So.
Thank you. Kaveh, perhaps we talked a lot about the regulation and the importance of regulation in Europe, and it's more or less limiting at the moment all the conversation we can have on stages like this. Is it the same in US? Because we tend to think when we are European that we are more focusing on regulation than American people or US. I don't think so, so I wanted to counterbalance this feeling.
For sure, the GDPR standard is a more extensive data protection requirement than what we have in the US around health information privacy, but at a fundamental level, the basic issues are the same. And in fact, as it comes to clinical uses, where you're looking at an intended use to diagnose or treat, all of the artificial intelligence technologies face the same issue, which is that if you're going to use a technology for a diagnosis or a treatment, we don't have a mechanism right now for approving something that isn't static after approval. So we can use artificial intelligence to invent, but we can't release artificial intelligence to be active after approval. It has to be reapproved, and this is a global issue. Part of the reason I make that point is that what I actually think is going to be a very important observation is that much of the best uses will not be around clinical judgment, because clinical judgment is the hardest to solve for. So much of what happens in healthcare and so much of what human labor is being used for right now is non-clinical, and all the examples that I gave you of tasks do not require us to address that issue. Reading a medical record, for example, or putting information into a system is not a diagnosis or a treatment. There's the artificial intelligence technologies that allow people time back doesn't have to go through that. So I actually think a lot of the innovation is going to rotate to the areas where opportunity is large and the regulatory rubric is lighter, because there's a lot of relief we can get from that.
Thank you. Another question, yeah. We have a question here. I don't know where is the mic. Microphone, please. Microphone. Here. So your name and your organization.
Okay. Hello, I'm Jouko Ahvenainen. I'm entrepreneur and investor, actually working especially with user health data nowadays. One question is wearable devices and the data from wearable devices. They are not yet typically clinical devices. Sometimes data is more reliable, not always. But anyway, it starts to be a lot of data from a lot of people, and also there are more and more devices all the time, blood pressure, blood glucose, and so on. How you see the future of wearable data and these kind of sensors that are coming to all people?
Thank you. What we can call the real-world data, maybe in some settings. Sebastian, you wanted to react?
I would say it's a very, very interesting question in the sense that some sensors which are not perceived as collecting personal data, let's say the GPS of your car. At prima facie, you would say that it's not a personal data. I mean, it's a machine, it's a vehicle, it's not me. But indeed, it's collecting many data on your behavior as a user, as a driver. The same way, for instance, an IP address. Usually you would say, okay, what's the connection between IP address and me? But if you are using your own computer, you have your own access, it will become a personal data. So the border is becoming less intuitive than it used to be. So the digital world makes data more interleaved, interconnected. In this sense, it requires to have, I would say, probably more holistic approach, more risk-averse approach, and finding the right balance again. Because the idea is not to block everything. It's not to limit the use of data, the sharing of data, at least to raise the awareness, and then to find the right approach to get consent, to get acceptance. And then, if you find the right way to get the agreement of the data subjects, of the citizens, then it's a potential source of a huge research domain to collect data again, and many behavioral approach. So for instance, if you do research on cancer, if you can have a better understanding what is the behavioral profile of a patient, what could have been the trigger? What is the correlation? Maybe with things which are unforeseen before is very interesting. But for these, you need to find a way which is fair and efficient. I think, again, the challenge is to respect the rights, at the same time to be efficient and not to block the research. And that's a challenge, but it's a challenge we can address. And again, human intelligence is able to address these kind of challenges. So we need to work together. We need to bring together the different expertise, skills together, to work together and to find a way to move forward.
Jordi, you wanted to react?
I just wanted to add that probably data from wearables will be more seamlessly integrated into these research operations than, for instance, the data that is siloed in health systems. So as you said, I mean, you have to make sure that the data is of good quality, robust, and all of that. But even, I mean, you can think about location from cell phones, and that has been used for tracking the pandemic, and that's a health parameter, right? I mean, location is probably one of the best predictors of health because of the socioeconomic factors. So this is coming, this is being integrated maybe more easily than with other data that is harder to be accessed, and it's HIPAA protected in the US, or it's with a lot of regulation from the health systems that is walled, but it needs to be sorted out, and the use of it needs to be streamlined with research.
And maybe just the last point I wanted to add. As we mentioned, regulation may be perceived as a framing constraints, or constraints which is framing or limiting our freedom. But at the same time, if you look at the new Data Act, which is currently discussed, it will force IoT providers, IoT solutions providers, to share data, to make them more accessible. So regulations can also be an enabler to say, okay, you want to use IoT device in Europe, then you will have to make them available to the end users. They should be able to reuse the data, to share it with other service providers, but also to the research. So there are opportunities to make things also more open while protecting and preserving personal data.
Very, very quickly, I think it's coming or it's here. I mean, now the full debate about behavioral medicine. So behavioral medicine, it's about behavior. It's not about clinical or medical data. And therefore, there's going to be a need to set up devices and regulations to gather this data in a way that is useful. And again, I get back to the intended purpose, because maybe the aim is not to have a perfect device qualify as a medical device to count the steps, because it's not needed. But the steps are important for a specific treatment, so to speak. So I guess we will need to find a balance, because sometimes when we talk about quality of data in healthcare, I mean, I get a little bit scared. It seems like the golden standard of quality of the electronic health record is gold. And when we dig in the electronic health record to do some algorithms, we see that doctors sometimes are not typing gold. So then the full concept of quality of data, it's going to be shaped by the intended purpose of the use of this data in the decision-making process of the doctor or of the manager or of the health professional or no health professional. So I think it's important to realize that behavioral medicine will gain more and more importance, and there is going to be the need to support this with new data coming from new sources, so to speak.
Kaveh, you wanted to reflect on that?
I'll just add one comment, which is I think that we've talked a lot about, when we think about wearables, we think about intentional data. But in fact, we're now recognizing that a lot of what I'll call unintentional data is being produced. And if privacy is a hard thing with intentional data, imagine when the data is unintentionally produced and can be used for other purposes, like your location or your contacts or your temperature in an ambient way. I mean, it's opening up an interesting policy issue.
Yeah, well, at the end, when we listen to Amazon, for instance, on their strategy on healthcare, saying that they have already a certain number of data around their customers, that could help actually on their health, even non-clinical data. So this could be seen as a challenge, but it could be seen as an asset as well for some players like them to penetrate the healthcare sector, for sure. One last question. mic here, the first line. If you can specify your name and your organization, please. An expert on the AI, actually.
Sorry. Okay. Well, thank you for the presentations. My name is Africa Periañez. I'm the CEO and founder of BenchAI. BenchAI is a startup fully funded and working together with the Bill and Melinda Gates Foundation. And we focus precisely on what Francisco has said about behavioral machine learning for low and middle income countries. So we provide adaptive intervention in real time through mobile health apps. So my question is, if you have an opinion, or what do you think, what is the future of Africa for the mobile health apps in terms of data and also AI?
Jordi?
I guess I alluded to Africa before, and I worked on a few projects over there. So technology-wise, I was amazed on, I mean, I think this probably is one of the most effective ways to getting this to the African population, like to measure things, to have health interventions, because it's amazing how the mobile world has impacted the life in Africa. I mean, probably easier sometimes than doing certain more classical interventions. So in that regard, I think that's definitely a way to go that has a lot of potential. I just want to say that.
I would welcome you to the next event we will have with Africa Health Business Association, because I think it could be a good place to push your offer and your model as well. Any other reaction, gentlemen? No? Do we have? Yeah, we have a question. I will take the last question here. We are already over the time. A microphone, please. Here in the middle. Please tell your name and your organization.
Okay. Hold up. Scott, I have to hold it for you.
Okay. Okay. So, hello, I'm Edu. I'm working in innovation in one Spanish hospital called Park Sauli. And I would like you to validate a dilemma that I have right now, that I see much more projects in the analysis phase of the data than in the storage of the data. So I see many startups and projects in one side, and it's quite unbalanced, in my opinion, in front of the storage phase. Is this all right? What you're thinking about this? Is this a driving technology? What do you think about that?
Out storage. Sebastian.
I would say there is a very interesting evolution at the European level with European data spaces. There is a massive effort invested by many startups, research projects, industries to develop a European data space for medical data and health data. And that is coming. So there's a lot of research in this domain, but it's not necessarily very well known and publicized. So this is coming in parallel. And the idea for this European data space is precisely to find a way to aggregate and to make as many data as possible available for research, for new services, innovative services. So it will go hand in hand. But it's probably not so visible yet because the process and the research is done at a larger scale, but not really publicized, I would say. And perhaps, I don't know if you would complete. So this is coming. But it's not the same process because you need really to discuss and to mobilize large resources, so more massive investment for that.
That's a very good question, and I mean, my first reaction would be, I guess the data storage is locked. The innovation is locked by big players. There is no space for small players to do innovation because at the end of the day, there are just a few working in that area. The second point could be considered a commodity. I mean, I think we are moving from a product-wise, I have my servers, into a service-wise, I have a service provider. So storage maybe is not that sexy, you know what I mean? However, it's a very good question. It's like, and I don't have a specific answer, just these two lines. There is a monopoly there, big players. Your hospital is gonna deal with the big players because they don't want to put in risk this critical capacity, so let's not innovate there. Second point, the big players are trying to move to the service because they know that they may be moving to the cloud soon and they cannot sell more machines, okay? And this is why it's a moment where innovation may not be there, so to speak. But it's just an hypothesis.
Thank you. So we will stop the panel now. We are out of time. Thank you very much, and we can upload them to the speakers and the experts we had this morning. Thank you very much.